First of all, let me express my sincere thanks to Bangladesh Cardiovascular Interventional Society, particularly Professor Azam, Professor Mir, and Professor Rahman for the kind invitation. Well, friends, as you know that calcification in the coronary arteries has been one of the most important challenges for the interventional cardiologists over the past 4 decades. Calcium is like a rock. It prevents inadequate delivery of the stent, inadequate expansion of the stent, and therefore the complications related to inadequate expansion, delivery, late thrombosis, high incidence of restenosis. Well, we all know that several tools have been made available to us for the treatment of calcified coronary arteries in elective cases. But we as yet don't have much experience or have much devices to treat patients who come to us with acute myocardial infarction, and on angiography you find that the infarcted artery is highly calcified and the results are suboptimal. So today's talk would be concentrated primarily on how to treat patients of STEMI with severely calcified coronary artery disease. Well, surprisingly, you would note here that 2 major trials, Horizons and Acute, when they analyzed the data, they found that there is a high prevalence of severe calcification in the target lesions in patients who present to them with STEMI, and the incidence was almost about half of these patients. And obviously, calcification prevented inadequate expansion of the stent, led to a high incidence of stent thrombosis and the need for target lesion revascularization at 1 year. Unfortunately, the use of rota ablation in these cases was very, very low, less than 1%. And there is very scanty data on the use of rota in primary PCI. Now, why rota has not been used for severely calcified coronary arteries during the stage of infarcted artery? Its use is controversial, and even the manufacturers do not recommend its use in acute myocardial infarction. There is no difference in the angiographic and the safety outcomes when compared to PCI with or without rota in these patients. Now, why rota should not be used in patients with the STEMI with calcified coronary arteries? Well, it's very well understood that STEMI is a highly thrombotic state. There is a risk of further platelet activation, and this can lead to a slow flow which is already pre-existing in these patients. So slow flow or no reflow is a major challenge once you treat acute myocardial infarction, and there is a potential risk of perforation because of an already ruptured plaque in these patients. We have a small experience of vast number of rota ablation that I have done over the past 25 years. We have treated 6 patients during the primary phase of acute myocardial infarction with rota ablation in patients who had highly calcified coronary arteries. Now, one of these patients had left main with the triple vessel disease, 4 had triple vessel disease, 1 had single vessel disease, and 1 had 2 vessel disease. Now, let me show you some examples and then explain to you how this works. The cines are not working. This is the first case where you can see that the patient has got a very diffusely diseased 100% right coronary artery. Look at the left coronary artery. The only surviving vessel is a circumflex obtuse marginal branch, which is also diffusely diseased. And then there is a ramus branch, which has also got a high-grade stenosis. The LAD is totally occluded. Next. Yeah. So we were able to cannulate this totally occluded artery, and therefore after thrombosuction we could see that this artery is highly calcified. You can see in the AP cranial view that is the diffusely diseased highly calcified LAD. Next. And then, therefore, at that stage, we did serial balloon dilatation, but we were not able to get a full result. So we decided right at that point of time to do a rota ablation on this patient. So we exchanged it with a rota wire, put a 1.25 mm burr, and after doing 1.25 mm burr, next. This is the final result after doing putting in 2 long stents. Now the patient's flow is established. Patient was stable after that, and the blood pressure improved. Next. So during his hospital stay, the patient remained uneventful. Blood pressure was 100 to 110. Ejection fraction improved over the next 5 days to from 30 to 35%, and he was discharged on day 5. Next. Now, this is another patient of rota stenting in LAD where we had to do a left main bifurcation stenting in a patient with STEMI. Next. This is 68 years gentleman. Next. BP was 90. You can see that TC shows the extensive anterior wall MI with right ventral branch block, left anterior MI block, and also a lot of VPCs. This patient had a previous device implantation about 10 years ago. Now he came to us. The right coronary is totally occluded, again like the previous patient. The LAD is 100%. The only surviving vessel is circumflex, which seems to be reasonably okay. Next. So now we we cannulated this LAD. We were able to do some thrombosuction, and after that we found that it's a highly calcified LAD. Next. And then went ahead and did a rota ablation using a 1.25 mm burr. Yeah, so this is after deployment of a DS in the proximal LAD. Now you can see here the vessel is now having a TIMI-3 flow in the LAD, but there is some plaque at the origin of the circumflex. Next. So we did not want to leave a circumflex at that point of time because circumflex was a very important vessel to this. So then we deployed another stent from left main to circumflex and like a inverse T, and then did a kissing balloon dilatation, and this was the final result. So the patient was okay after this, that stent being deployed from LCX to left main. Next. So this is the final result. Now the last case that I will show you next. This is due to inability of the balloon to dilate a very high grade stenosis in the LAD. Next, patient having STEMI anterior wall MI, 62 years old male. You see here in the AP cranial view there is a subtotal occlusion of the LAD, but with a tight stenosis at the LAD diagonal origin. And this is the pre-PCI left coronary angiogram. Next. And the right coronary artery also is totally occluded. Next. Now we passed wire in the LAD and also a wire in the diagonal to save this diagonal, did a balloon dilatation both of the LAD and diagonal. And you can see here that the balloon has not been able to fully crack the waist at the particular point where the diagonal is originating. Next. And this is the post-balloon result. There is a tight stenosis which is persisting at the origin of the diagonal in the LAD. Next. So at that point in time, we did a IVUS. You see a thick layer of 360-degree calcification, which is almost, which is quite thick calcium. Next. So we thought we will not be able to break this calcium, so we resorted to 1.5 mm burr. Next. So rota was done, and after that we deployed next 2 long stents in the LAD. Next. And this is the result after deploying 2 long stents in the LAD. The proximal and mid vessel seems to be all right. The diagonal has been preserved. Next. So lastly, RCA. Next. This patient is a 71 years old female, and he came to us with inferior wall MI. Next. Now you see the right is totally occluded. Next. We wired this and did as usual the balloon angioplasty. Next. And then thought we would put a stent, but there was a tight waist in the balloon which would not disappear. Next. And then at that point in time, next, go to next. We did a next. We did a IVUS, and like the previous patient, we had a 270-degree thick layer of calcium at that place where the balloon was not yielding. Next. So we did a rota ablation, again using a 1.25 mm burr. You can see the burr being passed through that lesion. Next. And finally we deployed 2 stents. Next. Keep on going to next. Next. Deployed 2 stents. Next. Next. And the result was excellent with TIMI-3 flow. Go to next. Okay. So I think if we scan the literature, so I've shown you 4 out of these 6 cases that we have done. The survival was 100% in all these 6 cases. One of these patients, of course, developed a acute kidney injury because of the too much of contrast being used. When I scanned the literature, very scanty literature, only 47 patients have been reported in the world literature where rotablation has been done in acute myocardial infarction. The mean duration of rota and MI was 4 days. STEMI was, just go to previous, last slide. Non-STEMI was the majority and STEMI is only 7 cases, or that was about 15% of the cases. But the MACE rate was very high, both at 30 days and also at 12 months next. So in conclusion, use of rotablation may be considered in STEMI patients when the lesion is extremely calcified. There is an inability of the balloon to cross the lesion or dilate it adequately, and target lesion is associated with diffuse and distal disease. Avoid large bursts and high speeds. Use IABP if intractable slow flow or no flow develops, but we didn't have to use in any one of them. And overall, the procedure is highly successful and enables optimal deployment and expansion of the DES. Thank you very much.